Hello and welcome, everyone. Thank you all for joining us for today's program titled Advancing Equitable Access to Palliative Care Through New Jersey's Medicaid Benefit. I am Ivy, the Communications and Events Manager with Leading Age New Jersey and Delaware. It is wonderful to see so many of you today on this beautiful and warm spring day. I have a few quick things to note, some housekeeping items. We would love to see your faces. This meeting is being recorded, so if you would rather not have your face recorded, completely understand. That's up to you and your comfort level. Please mute yourself while you're not speaking, just so we can minimize any background noise and potential disruptions as we are moving through the session. And please feel free to use the chat feature within Zoom during this webinar to introduce yourself and ask any questions you might have. We will be monitoring the chat throughout and try to get to all of those questions today. And if we, for whatever reason, are unable to, we'll be sure to have those, recorded in writing and circle back after the fact. This program has been approved by NAB for one continuing education credit hour. And in order to receive those credits, you must attend the session in its entirety and complete a brief survey and attestation form afterwards, which I will send a link out to all of our registrants after the session. If you have any questions about that, please don't hesitate to reach out to me. We're also going to issue certificates to folks if you'd like to submit those to HUD for continuing education credit. So you can do both of those things through the form that I'll be sending out. We are really excited to be joined by Lori Feldstein, CEO and Executive Director at the Goals of Care Coalition of New Jersey, and Jill Schwartz-Shevlin, the Chief Medical Officer at VINCA. So without further ado, I will turn it over to our speakers.
Hello, good morning, or good afternoon. Where am I? Good afternoon, everyone. My name is Dr. Jill Schwartz-Shevlin. I'm going to begin. I'm going to start us off with a little bit of background, and then I'll hand it over to Lori. Before I introduce myself, what I would love for you to do is add your name to the chat and just your background, and what position you're in, and from what your interest level in this topic. Just kind of get to a sense of who's in the audience here, so we can get a sense of that. I'll give a little bit of background on who I am. I'm an internist by training. I'm a palliative physician, certified palliative physician. I've spent the majority of my career taking care of complex, frail, elderly people. Had a home-based medical practice for 11 years in the 5 counties surrounding central New Jersey, doing home visits to patients who had difficulty getting out of the home. And for the last 10 years, I've been involved in that same industry, but really with national value-based organizations that help to provide care to medically complex and frail patients that need additional assistance in a team-based approach to care. And so it fits really well with our subject today, talking about the New Jersey Medicaid program. I'm going to talk a little bit about the palliative care and what is palliative care, since I know that it's a complicated topic and it means a lot of different things to a lot of different people. So I'm going to share my screen and would love to know if you can see it. The thumbs up would be great. Okay, awesome. Terrific. And so I can also just share that VINCA, the organization that I currently work for, and I'm the chief medical officer there, is a palliative care company that is a tech-enabled company and really works to provide care around the country to many people, both in a telehealth way as well as in person. And so I have a few slides at the end, a little bit about Vinca, but primarily this is about palliative care. So let's start with what is palliative care? So let's define what this is and very often people think of it, what it's not, and describing those things, but it's defined as being specialized medical care for people with serious is a complex chronic disease that will ultimately have an effect on people's life, whether it's their quality of life or their caregiver's quality of life. But it creates significant symptoms and stress from that condition. It is not hospice. However, if we look at palliative care as being an umbrella, hospice is the last 6 months of that umbrella, right? Palliative care is further upstream when people are still trying to get aggressive treatment for their illness. So palliative care is appropriate at any age and any stage of serious illness. And it's also provided while people are getting curative and life-prolonging treatments. Now, I know this may be a little bit counter because in the hospitalized setting, when patients are acutely decompensating, we call palliative care, and it's really for end of life. But in the community-based setting where I've been living for many, many years, it really is a way of providing that wraparound care to patients at any age, at any stage of their disease. And it provides this extra layer with an interdisciplinary approach to care with nurses and doctors and social workers and chaplains and nurses that wrap really and help to provide that wraparound care, collaborating with primary care physicians as well as specialty care. So what do we focus on? We focus on symptom management, psychosocial support, and complex communication. When we talk about symptom management, often we're dealing with patients who have issues related to their treatments or related to their chronic complex disease. And it allows us to anticipate these symptoms in advance of people having them. So we set people up for success so that they do really well and not have to go to the hospital or not have to go to the urgent care clinic. And psychosocial support, so much of the diseases that we see actually has an impact on people's living situations, their relatives. Now their relatives may need to be informal caregivers. There's a lot of anxiety and depression that gets built up not only in the patient, but also in their caregivers. And that also triggers their need for acute care. And then complex communication. So when we talk about goals of care, we're talking about what puts the sparkle in their eyes. What actually do they really want to be doing? What would they love to be doing that they haven't been doing for the last several months or years? And how do we get them back there? Like, how do we empower their caregiving team, their village, to get them back to really enjoying and loving what they've missed doing? So addressing the needs of the frail and complex is primarily the focus of this care. And so when we describe the complex patient, this is a patient who has multiple different medical problems, and it could be from congestive heart failure, COPD, kidney disease, dementia, and we look to improve their symptom management, and we help to defragment their medical journey. And so we do this in a team-based approach to care. And so we know that there's a need for addressing symptoms, and it's the pain that we treat sometimes is not just physical pain, but it's emotional pain. And we know that we need to treat um, the setting in which these patients are. So it's not just the patient, but it's also the family caregivers that we're trying to manage with the caregiver burden and the stress that they have. And so it's nuanced pain control. It's sometimes, as an example, cardiac breathlessness related to their COPD or heart disease, but also their anxiety around that. Um, and then, as we talked about, psychosocial stabilization and really helping the whole family to anticipate what those symptoms are so that they are knowledgeable, they have the skills, they have the tools, they have what they need in their toolkit to be able to manage that patient at home, and everything's not a crisis. The other thing that we do is help to defragment their medical journey. Many of these folks have 6, 7, 8 specialists that they're running to from appointment to appointment to appointment. And they just are listening to their docs or their providers or whoever's there at those appointments, but they don't have anybody actually managing their care. And it's too much for the primary care providers often. And so what we try to do is we quarterback with our nurses and our social workers and our nurse practitioners and our physicians, and we have care team meetings so that folks feel like we are literally, we're really taking care of that whole person, and it's a whole person approach. And then it prevents that medical momentum. I call it like a treadmill or an escalator. Once you get on, you're like, how do I get off? And so it's this feeling of like, I didn't sign up for this aggressive treatment, but this is where I am because the doctor wants me to take all these tests and do all these things. And so we help to manage that, to go back to those goals of care, to say, does this align with what you really want to be doing? And then we support the family unit with, we understand, I mentioned caregiver burnout and the pressure and stress. We have these goals of care conversations, and we talk about what that quality of life looks like and what it actually looks like, rather than just going through a post form and we click that provider orders for life-sustaining treatment, rather than just clicking through decisions. Do you want this? Do you want this? But we actually relate it back to what's most important to you, and is this going to get you there? And then crisis prevention, I mentioned a little bit about that, but having the ability to be on 24/7. I know many of our physician practices and provider practices say, if it's an emergency, call 911. Well, you call us, right? We're available and there for you because we know that the emergency room in the hospital is not the best place for our patients with chronic, complex underlying diseases and our patients who are super frail. And the hospital is not going to be the best place to manage those patients. So just looking at a little bit of stakeholders, like who's here, right? If you're from an operations perspective, or you're a consultant or you're a developer. So why is this important to you? Looking at it, this helps to reduce the revolving door of hospitalizations and ER visits. It helps to also create a value-based care model. So it's actually reducing the cost of care for these very expensive patients. And then it's also designing a place where people can age in place, and we can reduce that turnover, and we create an infrastructure that helps to support these patients. So I'm just talking a teeny bit about the New Jersey Family Care Community-Based Palliative Care, and I'm going to hand it off to Lori. So this is the beginning of my end. So addressing the needs, what is this benefit that New Jersey has? First of all, it's like one of 3, and we are very, very lucky to be one of 3, to have this Medicaid benefit. But it's addressing the needs of the frail and complex, and it's helping to stabilize the high utilizers. So these are patients that show up in the emergency frequently, and they're going to the hospital and they're very complex. And so we talked a little bit before, it's proactive management. This benefit helps us to identify the patients early and then provide comprehensive care and ongoing management for these patients before they require an ER visit. It's also medication reconciliation. So we, as palliative care providers, we look at that list and we scrutinize the list of 27 different medications, all the different vitamins, all the different treatments that every specialist has used. And we're really seeing and scrutinizing, do they need this? And is this going to help them get to their goals? And then the comprehensive family support, as we talked about just a moment ago, the caregiver support is critically important. If that's not stable, the patient can't remain at home. That has to be a stable rock in folks' lives. And we know that in this population, that's ever changing. So we help to try to support those patients and their family caregivers or informal caregivers, the one next door who's getting the groceries, someone who's getting their mail, someone who would visit them in the hospital. We help to support them and bring them into the fold. And then again, always looking back in an iterative process, is this consistent with your goals of care? And we cover this as clinical conditions change, because we know that happens frequently. So what's the strategic impact? We want to lower the total cost of care for these patients while providing the highest quality care. And then we also know that this is an opportunity to track these interesting metrics that the state is tracking and will be tracking, to be able to identify like what's the volume that we're seeing through this program, but also what's the impact of this program on these patients' lives. So the role of Vinca is a palliative care, tech-enabled palliative care company. We provide advanced care planning a platform that can work with multiple EMRs, but also be communicative to the PCP, independent of their EMR. And we provide clinical partnerships for any in-house, for any, any provider group that might not have this palliative care layer. Because not a lot of groups actually provide this level of support with this interdisciplinary team. So we can work with provider groups, health plans, value-based plans. And so we have the agility to work with various different groups that could, so we can help to provide this level of care. And then we are also able to provide our, outcomes of the reduced hospitalizations, improved symptom score, and member satisfaction. So we are excited that Vinca could be a potential solution for this waiting for a crisis type of thinking, and we can provide that coverage for the gaps for these patients. And we're excited to be in this space at this time. I will send these out, but I will also just include these other slides that show a little bit more information on Vinca. So with that, I will stop sharing my screen and hand this over to Lori Feldstein.
Thank you very much, and great to be with everybody today. So I think that set the perfect stage, and thank you, Jill, for that comprehensive overview about what palliative care is. If you give me a second, I'm going to pull up my slides and we'll talk a little bit more specifically about the state of serious illness care in New Jersey and the opportunity for all of you to help support communication around what palliative care is and how it might help to support patients with serious illness across the state. So first I'll introduce myself. I'm Lori Feldstein. I'm the CEO of the Goals of Care Coalition of New Jersey, but I am also a daughter and was the primary caregiver for my dad. That's who you see in the center of the slide. Um, my dad and I in Costa Rica with our family. And that picture was taken exactly a month before my father was diagnosed with stage 4 cancer. We returned from this amazing trip, and after my father was diagnosed, he began treatment for metastatic melanoma. And unfortunately, my father died exactly 11 months after he began his treatment. And he spent over 200 days during that last year of his life in the hospital. Not where he would have wanted to have been, given that he's an outdoorsy, adventurous type person, as you can see from these slides, from these pictures. So as the primary caregiver for my dad, I saw very up close and personal just how much suffering not only my father experienced, but that I also experienced as his caregiver. And I kind of came out the other end of this experience after having lost my dad, feeling a bit robbed of time and thinking about how my dad and our family would have rather spent those last 11 months. Um, Simple things like, us being able to be at home and spending time with my dad. For my dad to be able to he might not have been able to hike a volcano in Costa Rica, but he certainly would have been able to take some nice walks in his backyard or neighborhood. He could have sat with us and had his favorite meatball pizza, cheering on his Giants or crying if they were losing. But these are some of the ways that I think as we reflect on what we missed in that year of treatment could have been changed had I known about palliative care. And unfortunately, nobody talked to us about what mattered most to him during that last year of his life. And we missed the opportunity, that precious time, because we didn't have access to that type of supportive care. So today I want to talk a little bit about the gaps that we are seeing specifically in New Jersey. What I learned as I got involved in this work is that the experience that my dad and our family had isn't different from the vast majority of patients in New Jersey with serious illness. So I want to talk a little bit about actually what we've learned about the gaps in care, and then talk specifically about the New Jersey Medicaid community-based palliative care benefit that you just heard briefly a little bit about, and how to engage patients in talking about palliative care with the hope of connecting people who are in need with programs and resources that are available. So that's pretty much the focus of the next couple of minutes. I'll just start by sharing a brief overview about the Goals of Care Coalition. For those of you who may not know too much about I do see some familiar faces, so I know that there are a few people on the call who are familiar with Goals of Care. But for those of you who aren't, our organization was founded back in 2018. We were founded as a result of work that had been ongoing for a couple of years under a governor's advisory council to study what the problem was in New Jersey with regard to end-of-life care and serious illness care, because many of the people who are involved understood what my family experienced, that end-of-life care in New Jersey has not performed well. We've not performed well on those end-of-life care metrics. And a lot more suffering was happening in our state than needed to be. And many of those thought leaders involved in serious illness care came together to study the problem, and they issued a report, which you see on the right side of this slide, which included 26 different recommendations and ways we could improve end-of-life care and serious illness care in New Jersey, the number one of which was to form a coalition such as ours to bring all of those groups together who were concerned and were working on improving serious illness care under kind of one umbrella. And so today, Our organization is a nonprofit. We have more than 40 different organizations and academic institutions as part of our coalition. And these are some of the organizations that are currently members. You can see Leading Age, and we're grateful to Leading Age New Jersey and Delaware for being one of the very first members of our coalition, one of our founding members, with an understanding that this coalition represents many of those organizations made up of the interdisciplinary team that you heard a little bit about earlier. So it's not just the physicians who care for people with serious illness, but it's also the nurses, the PAs, the social workers, chaplains, and doulas. And they are the organizations representing that interdisciplinary team who care for people in the hospital, in the community, in the long-term care setting, and those organizations training the next generation of providers. Our entire focus is making sure that patients with serious illness, we say, get the care they need and no less, and the care they want and no more. And our areas of focus are in research, advocacy, and education. I'm going to talk a little bit about that in just a second, because that research is really what led us to many of the advocacy efforts we've undertaken over the last few years. Excuse me. So I'm going to just share a little bit about research that our coalition undertook that was funded by our Department of Health and the New Jersey Commission for Cancer Research. And they provided the funds for us to study the serious illness care in New Jersey. And you'll see those results in just a moment. But what we learned is that it supported what the national organizations like the Coalition to Transform Advanced Care knew about New Jersey and studied about New Jersey. So you can see that arrow at the very end of this graph on the right side of the slide. That's where New Jersey falls in terms of our performance on serious illness care compared to all the other states in the country. So we are amongst the most worst performing states. And what that means is that our patients in New Jersey tend to receive more aggressive care, spend more time in the ICU, more days in the hospital, see more subspecialists, and at a cost of about 20% more than any other state in the entire country. So let that sink in for a moment. This is why our coalition was working so hard to try and transform the way we care for people with serious illness. And all of this doesn't bode well for those of us who are aging in the state. We are aging faster than our health systems can adapt. And I know you're all familiar with the statistics around serious illness or around the aging demographics in our state. But I want to highlight an interesting statistic I heard very recently, which is that by the year 2030, when we're going to have about 20% of our population over the age of 65, we will actually have more older adults in the state than we will have children in our school system in the entire state. I found that to be really surprising. But we know that the older adults in the state are going to be experiencing chronic and complex health conditions. And as a result, they will be relying heavily on our hospital-based systems, on our emergency departments, and on our long-term care facilities. And the members of our coalition thought that it might be important for us to start thinking about bringing care more directly to where people are to alleviate the strain on our already strained healthcare system. And that is why the members of our coalition became such strong, steadfast advocates for policy change that would allow for care to be delivered more directly to patients, home and community-based services brought directly to patients with the goal of trying to keep patients out of the hospitals and out of our emergency departments. And you heard mentioned earlier, the community-based palliative care program that our state is launching next month is going to be only the third state in the country to offer a community-based palliative care benefit through Medicaid. And so, I say often all eyes are on New Jersey these days because there are dozens of other states that are in the process of trying to advance a Medicaid palliative care benefit, but they're all looking at New Jersey to determine whether we can do it successfully. California's actually had a benefit in place for their Medicaid beneficiaries for over a decade, and I'm going to show you a little bit about the data coming out of California, which was very important to our successful policy and advocacy work here in New Jersey. And Hawaii launched their benefit exactly a year ago. So being the third state in the country gives us a really big opportunity to share the learnings from our state with the dozens of other states that are right behind us looking to bring palliative care access to more people. So this is the data I wanted to share with you. It's not surprising that we had success in our advocacy efforts because palliative care works. In California, in the Medicaid population, we found out after their decade of providing this kind of care to their most vulnerable patients with serious illness that for every dollar they spent on palliative care, they saved $2.60. It just makes financial sense. That translated into a per Medicaid member per month savings of between $231 and $1,165 for a total cost reduction of between 42 and 51% across the board. And all of that cost savings is really due to a reduction in utilization, which is what you see on the left side of the slide. So 35% reduction in ED visits, 48% reduction in hospital admissions, and a 50% reduction in overall hospitalizations for a total cost reduction of over 36%. Again, palliative care is good for the patients. It helps to improve their quality of life, but it's good for our state because it will help reduce costs. We also spent some time over the last 2 years studying the gaps in care, specifically in New Jersey. And unfortunately, and many of you who are on the front lines of dealing with older adults and patients with complex care needs won't find this surprising, but we found that there are significant gaps in our ability to deliver care across the state based on geography, based on disparities with regard to racial and socioeconomic factors. And so what I'm going to show you here is on this slide is that in the work that we did, we were able to identify only 79 specialty provider organizations in the state, and they line up pretty much along the New Jersey Turnpike, which means that there are great areas of New Jersey that are left underserved in the northern part of the state, specifically the northwestern part of the state and the southern part of the state. And even in the central part of the state, we have counties with very limited or no access at all to palliative care. So it's not surprising that utilization of palliative care in New Jersey is very low, but it's surprisingly low compared to the national average. So nationally, we know about 30%, 33% of Medicare beneficiaries with cancer access palliative care. But in New Jersey, it is only 5.2% of cancer patients who access palliative care. And even amongst the sickest of our patients, those with metastatic cancer, utilization is low at 12.4%. So we've got a lot of opportunity here to better support our patients in the state with serious illness. One of the other things we learned in our study is that for a state as diverse as ours, we are amongst the most linguistically and culturally diverse states in the country. And yet our care for patients with serious illness is offered only in English and to a lesser extent of the time in Spanish. But because we have so many households that are speaking multiple other languages, it's a real barrier, a significant barrier for patients to access palliative care when it doesn't exist in their primary language. And I want us to spend a couple of minutes talking a little bit about the other more really significant, important learning from our research. And I'm sure many of you, hear about this as well, but there is tremendous confusion and conflation between palliative care and hospice care. And it's because of some of the reasons Dr. Schwartz-Shevlin mentioned earlier, where, in the hospital, palliative care is often brought in to talk about end-of-life care, but in the community, palliative care is intended to be delivered much further upstream. And the problem is that people don't associate palliative care with upstream earlier interventions. They are afraid of this word. This word palliative is very confusing to people, and it inspires fear instead of what it should inspire if people understood it more directly. And this confusion exists not just amongst patients and caregivers, but unfortunately, many providers still confuse palliative and hospice care and talk about palliative care in ways that, again, more indicates more end of life care than more upstream supportive care. And that's something we all need to work on together. Um, we spent we spent a lot of time over the last year speaking to older adults, over 100 of them across the state, to really hear from them about what palliative care means to them. We also spoke to people who are receiving palliative care to help us understand how we might be able to explain it to people for whom there was really a low level of awareness, or even worse, a confusion between what is palliative care and what is end of life care. And what we learned were two really important things. One is that not only does the message matter, but the messenger matters. People told us that they want to learn about palliative care from trusted and well-respected members of their community. And so I can go out there and give this lecture to people in the community, but people told us directly that they would rather hear from people who are involved in their healthcare or respected members of their community who understand their culture and who speak their same language. This was really what it would take for them to be more open to the concepts of palliative care. And then they told us that what we're saying matters. So you heard earlier that palliative care is specialized medical care, and it's important that people understand that. But we have to follow that up with what that actually means. And even when we say it helps to improve quality of life, patients told us, yeah, they don't really get that either. So what do we really mean? And these are the important words: that palliative care can help by easing symptoms, reducing stress, and here's the really important part, by helping people living with serious illness have more good days at home. That's what people want to hear and need to know in order to be open to receiving palliative care. You also heard earlier us describe palliative care as that providing that extra layer of support. Again, we heard from people all across the state that they don't really understand what that means. So we have to follow that up with the specifics. That means your palliative care team will work with your doctor, not replace them, to help you manage the symptoms and stress, and that they will deliver care that's specific to your individual needs. And that might mean you will sometimes be able to speak with a nurse or a social worker or a spiritual care provider, depending on what your specific needs are. And that you will have someone to talk to 24/7 who can help you when you need that care most. We also know it's important for people to understand that they can receive palliative care at any age. And by the way, pediatric palliative care is also part of the new Medicaid benefit. But we want people to understand that they can get care at any time during their serious illness. And here's the important part of the message, even while they're still getting treatment. So these are the kinds of tweaks to the way we talk to people that actually has an impact. And finally, and most importantly, that the help that is available through palliative care is both for you, the patient, and your caregiver. And I'll tell you what we heard a lot from patients across the state is that they understand what they need to take on as a person going through serious illness, but what really added to their stress and distress was the burden they felt their care was having, the toll that their care was taking on their loved ones, on their caregivers. And when we explained to them that palliative care also is care for the caregiver, that was sometimes exactly what it took to get a patient to open up to the concept of palliative care. So a really important tweak on, again, how we communicate what palliative care is, that it's both for the patient and for the caregiver. And then to just come out and say, palliative care is not hospice care. You are all going to be in a position to be talking to older adults and people with chronic complex care needs, and all of you will have the opportunity to share these types of messages. And this is one of the most important ones, that palliative care is for people living like you and all, us living with serious illness, whether it's cancer, whether it's dementia or other serious illnesses, that this is for people who are living. And that while palliative care and hospice care do share some commonalities, hospice is about dying well, where palliative care is about living well. So we really want people to understand that palliative care is that type of care which is provided alongside your regular treatment, whereas hospice is focused on comfort care at the end of life. Again, palliative care is about living well, hospice care is about dying well. Okay, I'm going to jump in for the last few minutes just to talk about the benefit, and then we can close out with a couple of questions. So you already heard Dr. Schwartz-Shevlin mention to you that this new benefit is becoming available in April, and that the intent is to provide a specialized team of support in addition to their regular doctors to help Medicaid patients with serious illness manage symptoms and stress, and to help them navigate the healthcare system. What you see on the right are some of those services that are covered under this new Medicaid benefit. So patients who have access to this program are not required to have a terminal prognosis. Remember, these are patients who are currently living with serious illness. They do not need to give up their regular treatment. So that's a big difference from what they may have access to in hospice care. And it is designed to provide that crucial supportive services that ultimately help them live better and stay at home. And who is eligible? This is really important because our coalition, the members of our coalition, advocated for the broadest definition of eligibility so that the most patients could really benefit from this program. So patients who are eligible can either be Medicaid or dual eligibles who have a serious illness. Some examples of the serious illnesses that are covered are on the right. This is not an exhaustive list. This is just sort of some of the examples. And in addition to being diagnosed with a serious illness, patients also have to have some evidence of a reduced quality of life because of that illness. And that can come in many different forms. So they can either have some difficulty with one or more activities of daily living, or, and it's important that we note this is or and not and, or they have to have visited the emergency department 2 or more times in the past 6 months. And again, or, not and, or have had a hospitalization in the past year. That is a broad definition of eligibility. And so I think, I'm hoping that these are people that you may all be involved with on a regular basis. So we want to make sure that you understand who can qualify to participate in the benefit. And accessing the benefit is really actually easy. The first step is completing an eligibility screener. This is 3 questions only, and anybody can complete these 3 questions. You can, on behalf of an older adult that you see regularly, the patient themselves or their caregiver can complete this. And it's really meant to ensure that we meet the criteria. They have a serious illness, they've had some impact on their daily activity. And the third question is really meant to get a sense of what the patient or caregiver believes the greatest need is. Once this eligibility form is completed, it can be taken to the patient's regular doctor or to their primary care doctor or to their oncologist, for example, if they are dealing with cancer. And the second step is that the provider complete a comprehensive medical assessment. This is really the first time where there will be an inpatient visit that's covered under this new benefit. So there's specific reimbursement for completing this comprehensive medical assessment, which can be completed by a physician, a PA, an APN, or a licensed clinical social worker. So again, the first step is that referral screener. The second step is that comprehensive medical assessment. That is then submitted to the patient's MCO, to the patient's managed care organization. And if approved, then that patient has access to a care planning meeting that is led by a physician, a PA, or an APN, and then regular visits throughout the month by any one of the members of the interdisciplinary team according to the care plan. And that eligibility remains in place for 6 months when that patient then would need to be reassessed. So the floor on that monthly visit is 1 time per month. But if that patient requires many more visits in that month from any member of the interdisciplinary team, then the plan covers that as well. So this is the first time that we are able to offer a comprehensive supportive care team and set of services to Medicaid patients with a serious illness, and for that care to be delivered in the home or in the community. And I'll end with just a few resources that we are making available to help you all talk about this benefit and connect patients in need with providers who are delivering community-based palliative care. And so the Goals of Care Coalition is supporting 2 big initiatives. One is our ambassadors program, where we're going to be training community health workers, nurses, heads of leaders of community-based organizations, faith-based leaders, those of you who have the opportunity to talk every day with people who could really benefit from accessing this program. And we're training these providers and then providing a lot of information for them to go out into the community and deliver community education, whether that be at senior resource centers, in assisted living facilities, in nursing homes, or in community-based organizations. As long as the people for whom the benefit is intended to serve are there, we are encouraging ambassadors to go out into the community and give these talks. And we are also working with a number of providers, oncologists, geriatricians, primary care physicians, and encouraging them to speak to their patients for whom this benefit might be appropriate about getting access to this program. So I put my um, email on the lower right-hand side here. If anybody is interested in participating with us as an ambassador, and I know we've already trained our first cohort, and some of you, I recognize your names, are on this call. But we are looking for more ambassadors to help us educate people. Remember, you are the trusted resources in the community that patients want to learn about this program from. So I'd encourage you, if you have an interest in doing that, to be in touch. And I'll stop there and to see if there's any questions.
So, Lori, I'm just going to read one question from the chat because I think Jill and I had two different interpretations for the answer. It's from Myrna, and she wanted to know, are patients who are custodial residents in a nursing home and have Medicaid eligible to receive this benefit?
Yes, they are. Yes, you can receive this benefit no matter where you live. The difference is that the provider of the care cannot be the nursing home. So nursing homes themselves are not eligible as providers for the care, but an outside palliative care provider group can deliver care to patients in the nursing facility. So I just want to make sure that's clear across the board for everybody. The nursing home itself is not eligible to be a provider of this palliative care benefit. The hospitals and nursing homes are excluded from providing this care in the community. You
Well,
have
let me just ask this question. If the nursing home is the provider group, the nursing home is the provider group for the physicians in the nursing home?
Yeah, they're not eligible.
They're not eligible. And if the
The,
hospital
the
is the
patient,
owner
just one
of,
second.
yeah,
The patient is always eligible. This care may be delivered anywhere the patient lives. The restrictions are on the provider side, not the patient side. Were there any other questions in the chat?
So I'm just going to do a quick follow-up to that from Teresa Edelstein. She just wants to know, does that mean the nursing home or hospital must contract with the palliative care provider and pay the palliative care provider for the services?
They can contract with the palliative care provider, and the palliative care provider would bill for the service outside of what the nursing home is billing for their care for that patient. Is that clear, Teresa? Okay, good.
Thanks. And then Myrna has another follow-up to that. So in other words, if a credentialed physician does not salaried by the nursing home can deliver palliative care, the resident is eligible, correct?
If the credentialed physician
Right, not
is not salaried,
salaried.
yeah. So the credentialed physician would need to be um, credentialed through the Medicaid program to participate in the palliative care benefit. So, so yes, in other words, the credentialed physician who is not salaried by the nursing home can deliver the care to patients in the nursing home as long as they are appropriately credentialed for the community-based palliative care benefit through Medicaid.
Great.
So the palliative care provider does then bill Medicaid.
Okay. Andrea has asked the question, can hospice organizations be providers?
Yes, they can. And there are some specific requirements for providers to have expertise in palliative care. So we are encouraging hospices to engage in this benefit. And if they are led by a medical director who is a certified who is a certified palliative care provider who has certification in hospice and palliative care. That is the ideal situation. If the lead is a certified hospice medical director without specific credentialing in palliative medicine, then there are some continuing education requirements that the provider, the interdisciplinary team of providers, including the medical director, would be required to complete. There's 12 hours of actual specific training on palliative care that the providers would need to complete if they are not specialized in palliative care. And that actually, if you think about it, makes sense. Hospice providers are used to caring for people who are dying. And if we're doing this benefit properly, these patients are living for a long time and need to have the type of care that is consistent with their goals of getting back to living the quality of life they had before their serious illness. And it should make transitions into hospice much
Easy.
easier in the long run. And that's what we're seeing in the California data is that patients who enroll in the palliative care benefit and have the experience of palliative care when it is appropriate ultimately have an earlier transition into hospice care.
Thank you.
So here's another question in the chat that I'll share. Can an individual work with an individual in their home and qualify for palliative program?
The individuals the care that is being provided, the approved qualified palliative care providers that participate in this program need to have, there are required members of an interdisciplinary team. You must have a physician, a lead clinician that is either an MD, a DO, an APN, or or an APN or PA, and you must have a nurse, a licensed clinical social worker, and a chaplain. So an individual alone cannot participate in the benefit. You must have all of the members of the required interdisciplinary team to be able to participate as a provider in the community-based palliative care program.
I think that might be all of the questions from the chat. If I missed anything, please feel free to unmute and ask Lori or Jill the questions you might have.
Hi, I'm Lisa. I asked a question. So I work in an independent living with older adults, and this is such a great topic. It's never easy to have it like ourselves with them. How do we go about arranging like informational sessions for the residents and the families?
Oh, that is an awesome question. Thank you. That is exactly the role of our ambassadors. So we, as I said, we've just trained our first cohort of 15 ambassadors, and they are looking for community-based organizations and opportunities to go out and give a talk about what this program, what palliative care is, what the community-based palliative care program is all about, and how to access it. So if you are interested in having a talk in your community, please reach out to the Goals of Care Coalition. You can reach me directly. You can reach Beth, either one of us. We are happy to send our ambassadors out your way and give these talks. We are currently looking to start those talks in the beginning of next month. So as soon as people are ready, to invite us in, we're happy. We're giving these talks for free in the community. So if there's an interest, please do reach out.
Martin
Thanks for that
Klein,
question.
can you hear me?
Yeah.
Okay. I asked the question, if you're a non-Medicaid recipient, or how does your organization provide services, and how do you go about doing that?
Yeah, that is a great question. So this benefit is specifically for dual eligibles and for Medicaid patients, but the Medicare does cover some aspects of palliative care. So the physician and nurse visits are covered. Um, there are also the commercial payers also have small pilot projects or are testing out palliative care initiatives. So it really depends on the patient's insurance. And that we have a list of palliative care providers on the Goals of Care Coalition's website. We have a provider directory, which you can encourage, your clients and patients that you're dealing with to search by insurance, by geography, zip code, and they can identify the providers that are in their community who they can go to.
Thank you.
Yeah, I'd like to just elaborate on that as well. So, my recommendation would be if there's an interest in palliative care for folks, if they have anything other than traditional Medicare, that they should call their health plan and ask, because very often the Medicare Advantage plans, they have palliative care like services, team-based approach, chronic, complex, longitudinal care for people who are very medically complicated. So that's one suggestion, to call their health plan. If you have traditional Medicare and you don't have Medicaid, then traditional Medicare, like Lori said, does provide reimbursement for the physician and nurse practitioner. Unfortunately, the provision of care for nurses and social workers is covered under a little bit of a different benefit, which is called CCM, complex care management, and would require the practicing team to bill a little bit differently and have those services in place. But that is sort of Medicare, traditional Medicare's kind of backdoor to trying to provide this holistic approach to care. It's not so great because the reimbursement doesn't compare to the Medicare Advantage reimbursement. And so much of the care model is unfortunately, dictated by the reimbursement model.
Okay, I think we covered off on most questions in the chat. Lori's email address and mine as well have been provided. So if there's anything following the program, feel free to reach out to both of us or either one of us.
Yes, absolutely. Lori, Jill, Beth, thank you so much for joining us and sharing this really important information about the new benefit. I will send out an email later this afternoon or early tomorrow with the recording, a link to a test and request CEUs if you need that. And I will also include Lori, Beth, and Jill's contact information. So if you have any additional questions, you can feel free to reach out to them directly or reach out to me or anyone here at Leading Age and we'll get you in touch. Thank you all so much for joining us this afternoon.
Thank you. Thanks, Ivy, for inviting us.
Yeah,
Thanks so
thank
much,
you for
Ivy.
having us. Take
And
care.
thanks everyone for
Bye-bye.
joining.